Good morning. I'm supposed to talk on advances in wound care, WAC and beyond. I'm afraid at the end of my talk, maybe I'll emphasize more on what is traditional rather than what is new. So what are the objectives of wound care? We treat wounds to remove contaminants, remove all non-viable tissue, prevent or eliminate wound infection, and try and achieve wound healing as early as possible and allow secondary surgery on underlying structures like bone for internal fixation, grafting, or vessel, nerve, or tendon repair, and make the healed limb finally look as close to normal as possible. Our experience is that for complicated compound fractures where there is extensive soft tissue injury or degloving injury, injury to vessels, injury to muscles, nerves, it needs collaborative care. And the key players in this are the orthopedic surgeon, the plastic and reconstructive surgeon, and sometimes the vascular surgeon as well. In all wound care, the maxim number one or the biggest, most important factor is that debridement is paramount. And all methods, or new or old, of wound care are secondary to a proper debridement. When do you debride? Debride now, as early as possible. Don't wait for something like this to happen, where the skin has undergone necrosis, and when this has happened, infection is already set in the deeper tissues. It's a bit too late. Now, this is an example of a grade 3 compound tibia which was referred to me a week after the injury. After inadequate debridement, pouring pus, severe Acinetobacter infection, inadequate debridement, lots of loose bone pieces have been held together with stitches, and the fixate is unstable. And you see the X-ray, how many loose bone pieces that don't have any soft tissue cover have been retained. And this is after proper debridement. Even this exposed bit of diaphyseal fragment, that also was resected at the time of flap. And after thorough debridement, when you put in a flap and a proper fixation, everything heals and it all achieves a good wound healing, and then it's the best stage for the bone to heal eventually. Now, when to debride as early as possible? Debridement should be performed by a senior surgeon, not left to the juniors, and should be done as far as possible within 24 hours of injury. In compartment syndrome, if it is suspected, then you must get in much earlier and debride quickly. Debridement can be done under tourniquet with sharp dissection, removal of all contaminants, remove loose bone, look for injury to vital structures and tag them, and then do a second round after vascular or second round after the tourniquet is released. Especially if there's a vascular injury, debride and stabilize before going ahead with the vascular repair, and debride again after restoration of circulation. Now, what are the new technologies available for debridement? So, new things that have come up: hydrosurgery with a powerful jet of water, that is the Versa jet marketed by Smith and Nephew. Then there is ultrasonic therapy, and there is plasma-mediated ablation therapy. This plasma is not the blood plasma, but it is the fourth state of matter, which is a highly energized state of matter, which earlier was created in a very high temperature environment, but now the technology has made it available at normal or body temperature. So this is the Versa jet, which is works on the Venturi principle. There is a very fine jet of water that flows across the probe, and it creates a negative or suction effect, causing removal of debris and its suction away from the. And depending on the force used, the Versa jet can debride superficially or mid-level or deeper tissues. And this is the
and remove little or no tissue with
this
each
is
pass.
how it is. And in
As the power increases,
if you increase the power, it can take off more deeper and deeper layers of debris.
The highest power.
Then this is the ultrasonic therapy, where similar effect is achieved with high frequency ultrasound. And this probe is held at a distance of about half a centimeter away from the wound, not directly in contact, and it helps to debride the wound and clean it up free of infection. The third is this bipolar radio frequency energized molecules via active probe or an electrode, with the focused plasma field, which helps debride and free the wound of infection. And a comparison of the three methods that I've shown shows that the Versajet works in wounds where there is fibrosis with the presence of infection, but in bleeding wounds it doesn't work very well, whereas the plasma works in achieving hemostasis as well as freeing the wound of infection and clearing up the debris. However, after all this, debridement of loose bone is the most critical thing, because if you see, this wound has healed very well, the flap has settled, but a loose piece of bone that you see here has caused breakdown of the wound distal to the fracture and caused non-union. Similarly, retained non-viable bone in this patient, as seen here, has prevented the fracture from uniting even a year after the injury. So loose bone fragments are avascular, do not contribute to fracture union, merely serve as a source of infection. And the fracture segments lose their endosteal blood supply, and when the soft tissue cover is lost, even the periosteal blood supply is lost. So there is no logic in retaining them. What to do after debridement? Fix and flap, as was described by a Yugoslavian plastic surgeon in the 80s, Marko Gudina, who showed in hundreds of cases that if the flap cover is provided in the first week, the associated infection rates are much lower. So this is a compound fracture that was treated, fixed immediately, debrided, put in temporarily negative pressure wound therapy, and then a flap cover was done and went on to achieve stable union within a few months. If immediate cover is not possible, then other methods of wound care come in. And what are the most commonly used method is the negative pressure wound therapy, commonly known as WAC, which is a bridge to reconstruction. It cleans up the wound, gets the wound ready for subsequent reconstruction. And what is new in negative pressure wound therapy? So we have over the years modified this to use it in the presence of external fixators like this, or with an extensive wound affecting the entire lower limb, we put it in a plastic bag, seal the top of the bag, introduce foam and catheters inside, and apply suction, and it works just as well as the NPWT for small wounds. And with the presence of colostomy or urostomy stomas or in the perineum, we are able to modify this and use negative pressure wound therapy even for extensive degloving injuries around the pelvis with a colostomy. Now the next generation of negative pressure wound therapy has introduced a irrigation system. So this is WAC with the irrigation system. It's called VeraFlow. And not only it cleanses the wound with installation of topical wound, and here you can change, you can instill antibiotics, antiseptic solutions, or the other newer modalities that I'll talk about later. It cleans up, it treats the wound and prepares it for subsequent primary cover. And several studies now have shown the efficacy of irrigation vacuum dressings over standard traditional vacuum dressings. But there are yet no studies comparing the use of plain saline versus antimicrobials. And this is an example where we have used it for a diabetic ulcer over the ankle, with the joint was exposed, and within 2 sessions of this irrigation vac, we were able to get the wound clean and ready for a flap cover. But is negative pressure the magic wand of Harry Potter? Not at all. It is just a preparation for the bed for eventual definitive skin cover. However, it may temporarily take away the need for a flap. What you think in the beginning needs a flap, you can get away with a graft, but later on, if subsequent surgery on underlying structure is required, you need to replace it with a flap. Now, what are the advances in local wound therapy? So this is the age of antimicrobial resistance, and anything that helps to, that is a non-antimicrobial wound therapy will help in this era of antibiotic resistance. And bacteria achieve resistance in multiple ways, and particularly in the presence of biofilms, they achieve resistance by persister cells or by transmission of genes across bacteria of different kinds, not just the same kind of bacteria, but across different kinds. And alternative therapies have come up to replace or to fight this antibiotic resistance. There are therapeutic bacteriophages, or bacteria that kill other bacteria. There are antimicrobial peptides that work against bacteria. And there are what is called reactive oxygen species, which induce injury to the bacteria by oxygen stress. So this is cold plasma and this photodynamic therapy. And these are the new modalities that have come in, but they are expensive, have been tested only for small wounds. Silver impregnated dressings also, it's a time-honored use in the form of silver nitrate, but now the nanocrystalline silver has come and shown very good results because it does not combine readily with local peptides and get deactivated. So the few antibiotic like Mepilex and Acticoat, which have impregnated silver, and it is effective against all kinds of organisms. And it can be left in place for several days rather than daily change or few hourly change. Then there are the surfactant solutions that break the biofilm and allow penetration of the antibiotic in the biofilm.
So your time is over. Kindly sum up.
So to summarize, debridement should be done as early as possible. It should be thorough. Loose bone pieces should be removed. Negative pressure wound therapy is a bridge to reconstruct, not a substitute for it. However, of all, negative pressure is well established, time tested and cost effective, and it will work if debridement is complete. Thank you.